So we're just having a few technical glitches there. Sorry, I'm a bit distracted. This is my first Facebook Live comment. My first time ever seen a Facebook page. So that'll show you how technically savvy I am. So my name's Louise Fay. I'm a fertility specialist with IVF Australia. I have been with them since I trained in my subspecialist years, since 2006. And I also trained as an obstetrician and gynecologist in Ireland, in case anyone was wondering where the accent was from. I work as a subspecialist, fertility specialist in our offices in the city and in Bondi Junction. And I'm also a consultant obstetrician gynecologist at the Royal Hospital for Women in Randwick and Prince of Wales Private Hospital. I thoroughly enjoy my job and have a very interesting career in fertility. I'm just keeping in touch with Julie to make sure there's no further technical glitches. Tonight's topic is to discuss unexplained infertility, which does encompass approximately a quarter of what we see in fertility clinics. And this would account globally, whether you live in Australia, the UK, Europe, the US, in Asia, Southeast Asia, Africa. So I think from an interactive perspective, I was just going to talk a little bit about unexplained infertility. And then I can see everyone who's online, they can ask questions. Feel free to ask questions throughout the session or just at the end of the session, and whatever you're most comfortable with. So just starting as a bit of a background, some of you who are online this evening may have recently seen a fertility specialist. Some people may not, or just exploring their options. Some people may have been trying for a long time. Some people may already have children and are having difficulty to conceive their second child. A lot of what we do in our work as well, which doesn't really encompass infertility, but encompasses our fertility program, would be the use of donor sperm, eggs, all across the board for couples who have difficulty achieving pregnancy, for women who are single, for men and women in same-sex relationships. In essence, about statistically 1 in 6 to 1 in 8 couples will need to consult either their GP, a gynecologist, or a fertility specialist to discuss fertility. That would be a global statistic. In Australia nowadays, approximately 1 child in every classroom, i.e. depending on the classroom size, but anything between 1 and 20 to 30 children are born as a result of fertility assistance, which clearly has seen a huge rise in fertility treatment since the late 1970s. The first baby born as a result of assisted reproduction in the context of IVF was quite a famous lady called Louise Brown, who celebrated her 40th birthday last year. But fertility assistance in the context of using medication has been around since the early 1960s. So when we investigate people in terms of difficulty conceiving, we are looking at both, obviously, the male and female side. So just as an add-on to that, we do like to see, whenever possible, a couple coming together to discuss fertility, because obviously, even though you might have a pre-existing condition that you might have been counselled that may cause fertility issues, we like to see couples together if they're in a heterosexual relationship, and that's the unexplained infertility. So unexplained infertility is really when we investigate a couple and we can't see any significant issues relating to sperm, relating to the pelvic organ, relating to ovulation. So just to delve into that a little bit further, I won't go into too much detail. So obviously If we look at the female first, a woman between reproductive age of anything between, say, 18 to 42, 43, who has a regular cycle, and a regular cycle being anything between around as early as 21 days, because that time for the egg to develop can be quite short, up to 35 days, with regular menstrual cycles, preferably off contraception for about 3 to 6 months to allow, especially hormonal contraception, to allow menses to resume. We do have definitions of difficulty to conceive, and primary infertility is someone who hasn't conceived after 12 consecutive months of trying. Secondary infertility, obviously, is somebody who has been pregnant. It doesn't matter if they have opted to have a termination, if they've had a miscarriage, if they've had a late miscarriage, or if they've had children, whether they've had 1, 2, 3, or whatever many children, but there's been a previous pregnancy. The female investigations that we perform, so obviously we take a detailed history, and we go into quite a lot of detail from when the first period started in a woman's reproductive history, so that's called menarche. And even though statistically it does happen a little bit earlier now, that in a more modern society, anything from the age of 10 to about 16 will be normal. So looking at menstrual flow patterns. So, and some people do come to us a little bit later in life, having been on the pill maybe for about 15 years, which is fine, and have difficulty kind of remembering, you know, I can't remember, did I go on the pill for period problems or did I go on the pill for contraception? Some people have very clear memories of very, very painful periods from the get-go and needing to go on the contraceptive pill for that reason. And some people have very clear memories of having like very, very irregular menstrual cycles, might have been associated with really bad teenage acne, and going on the oral contraceptive pill for that reason as well. So menstrual cycles are very important. The length of a menstrual cycle, the nature of the flow, how heavy the flow is, if there's any pain, if there's bleeding in between periods, if there's bleeding after intercourse, if there's bleeding before a period comes, if there's difficulty achieving intercourse, whether it's superficial or deep, if sexual intercourse is infrequent or frequent, and if it's related to any pain with that. You can be quite confident that you're ovulating if you have regular menstrual cycles. Some people come to us and they have tracked either using an app or using prediction kits, so urine prediction kits. And other people have had cycle monitoring or indeed investigations done elsewhere. So looking at the cycle in greater detail can often help people pinpoint exactly when they're going to ovulate, because that's a very important time for timed intercourse, especially in the context of trying. Obviously, it doesn't always have to be timed, but the egg is a very, very delicate single cell, and it must be picked up by the sperm once it's released from that follicle mid-cycle around ovulation. So as you know, as you probably are aware, women get their eggs when they're in their mother's womb. They have as many eggs as they're ever going to have in their lifetime when their mum is pregnant with them. So technically, when your mum carried you, she was also carrying her future grandchildren, so to speak, in a very primitive way. And that egg number is finite, and it's used up during our reproductive life. So the quantity of eggs that you have is related to a hormone level we can do called an AMH. So some people would have may have had that done in the past. And it's also looked at on ultrasound scan in the absence of using any hormonal contraception. So we can generally estimate from a blood test and an ultrasound scan what the ovarian reserve is like. Now, in the context of getting pregnant, this is not a marker of fertility, but it certainly can help us guide people as to whether there possibly might be issues in the future. So say a woman with polycystic ovarian syndrome would have a very high ovarian reserve because there is a kind of an excess or an abundance of primitive eggs. In a woman who has started to have very erratic periods, and possibly her mom had an earlier menopause than normal, which would be kind of under the age of 40, the AMH would guide us as to whether they needed intervention sooner rather than later, or any fertility preservation methods. So a pelvic ultrasound scan is a very comprehensive, so a high resolution scan, preferably in a gynae imaging centre, is a very useful way of looking at the pelvic organs. So this will look at the ovaries, like I said before, and look at how many eggs are being recruited in a cycle. It'll also look at the shape of the uterus. Is there anything there that may give any idea as to why pregnancy isn't happening? So say, for example, a big fibroid sitting in the cavity of the womb that might be associated with heavy periods, or a very rigid uterus that might have appearance of having endometriosis. And in addition to that, when we send people for that test, we also look at tubal patency. So we put some sterile water into the cervix, so like having a pap smear, and we can look to make sure that the fallopian tubes are open. So in the context of having normal regular cycles and normal pelvic anatomy, and possibly with no pain, normal flow, and no abnormal bleeding, the other thing we move on to is looking at the male reproductive system. Now, usually men are well androgenized, they've had puberty at a normal age, the testes are normal. If there's no history of any testicular trauma, infection, any congenital problems such as an undescended testes, you can probably generally assume that the semen analysis will probably be normal, but you can't tell unless you have a semen analysis done in an andrology lab. So an andrology lab is a laboratory that's dedicated to looking at sperm. And why we like that best is to have sperm looked at within a very timely manner, because sperm needs to be looked at because it'll lose its motility quickly. So in a single ejaculate of seminal fluid, there should be millions and millions of sperm. And you probably think, is it really necessary for like millions of sperm to reach one single egg? But in fact it is, because fertilization is a very, very particular process. So when we look at the sperm, we look at the concentration. So that's the kind of sperm density. So how many million sperm are in a single milliliter of seminal fluid. We look at the motility. So we look to make sure that the sperm are swimming in a nice fast forward fashion. And we also look at the shape of the sperm. And because there's so many millions of sperm in a single ejaculate, it's quite frequent that a lot of the sperm keep going around in circles, swim backwards, or they might be kind of abnormally shaped. And that's permissible because there's so many millions there, but they have to reach strict criteria to be called normal. So other things that may influence fertility, which doesn't really put it into the context of unexplained, but to just give a general overview for a couple of minutes, is just somebody's previous medical history, surgical history. So for example, having any ongoing issues with thyroid disease, such as a very overactive thyroid, if a woman has had significant problems with rapid weight loss, eating disorders, if somebody's had a very bad appendix, a complicated appendix in the past, where the appendix is down in the pelvis and may have damaged the fallopian tubes. Family history is important. When how many children did the girl's mum have? Did the male's parents have? Just a general overview. Lifestyle factors are important. It's important for people to have a healthy diet. Obviously, to minimally take alcohol when they're trying to conceive. Smoking is very detrimental to sperm health. Okay, so we're back. Julie's just going to send me all the questions that people had sent. Sorry that we just lost them for a bit, and I'll answer them. So just continuing on, when I was talking about the rest of the investigations. So let's just say all of those investigations are done and where we're at. So you have a semen analysis performed, you have confirmed ovulation, The pelvic anatomy is normal, judging by the high resolution pelvic scan that you've had done. There's no concurrent medical disorders that may impact on fertility. There's no past history for either partners. Lifestyle is relatively good. Both have a normal BMI. Both are non-smokers. No history of excessive alcohol consumption, marijuana use, illicit drug, especially for men, because obviously the sperm are constantly underproduction, and therefore they can be impacted more with alcohol and smoking. So where do we move from there? It's relatively easy in Australia to organise all of these, pending your geographical situation. Sometimes people need to, if they live remotely, need to go to larger centres to have the andrology and the pelvic scanning done. I'm just going to have a look at your questions now while we move on to why fertility can be unexplained. So some people are saying, I have pre-existing endometriosis that has been resected, but pregnancy isn't happening. Is this considered unexplained, or is that explained by endometriosis? So that fertility would be explained by the endometriosis as long as the semen analysis is normal and the tubes are functioning. Unfortunately, now we could have a whole other Facebook session on endometriosis that might last a few hours. But unfortunately, with endometriosis, even if you resect the endometriosis, you're resecting what you can see. The inflammation caused by the disease can cause, unfortunately, an ongoing problem with endometriosis. So in the context of removing endometriosis, we do see natural pregnancy rates go up after the first 6, possibly 12 months. But another big factor that I haven't actually kind of touched on yet is really around the female age, because egg quality starts to get impacted around the age of 35, 36, and that can also add that extra layer of complexity to unexplained infertility. In terms of failed fertilization at the time of IVF, that wouldn't be unexplained infertility. That's quite a significant problem. So I'll touch on that later. Another question was, when you're using donor sperm, at what point do you know the female has infertility issues? How many poor blastocysts through ICSI and how many failed transfers? So that, in the context of, doesn't really kind of come under the umbrella of unexplained infertility. Obviously, if you're using donor sperm because of male factor issues, or you're using donor sperm through women achieving pregnancy in a same-sex relationship, or a single woman achieving pregnancy. So it depends on where the patient lies. But in terms of a blastocyst, for those people who have never had any conversation about fertility issues, is about 5 days after fertilization when cell division takes place. So naturally it would be in your fallopian tube. In the laboratory, obviously it's in a petri dish, and the cells divide and exponentially grow, and the blastocyst is that bunch of cells that's placed inside the womb. So naturally, when it happens, it rolls down your fallopian tube and a blastocyst implants in the lining of the womb. In an IVF cycle, the blastocyst is created in the lab, and that's what we put back in at the time of an embryo transfer. So poor blastocysts, obviously that means poor quality blastocysts, and therefore that can have a major impact on people's chances of pregnancy. So a failed transfer, or how many transfers do you need in order to put yourself into the kind of proportion of people that might not achieve pregnancy through IVF? It would very much depend on how many blastocysts one can get in a cycle and what the quality of the blastocyst is, because there is a grading system that people use internationally and look at the quality of the blastocyst. So if there's poor quality blastocysts where the cells are quite fragmented, one would have to keep trying to achieve pregnancy usually between 4 to 6 cycles of IVF before we would consider stopping treatment, and obviously very much also dependent on the female age. Another question was 6 years of unexplained infertility with IVF, everything looking excellent on paper. Gene testing, how long do you suggest a couple continues with no answers? Do you suggest donors, even both sides had no issues? Now that's a very difficult situation to be in, because 6 years of infertility is quite a significant long time, especially if somebody's starting to try and get pregnant in the females, that is, in their late 20s, early 30s. Now, just to reiterate, men's fertility is impacted by age, but not obviously as early as the female. So, suggesting couples with no answers. So obviously, if it's completely unexplained, so no issues with sperm, no issues with eggs, have gone down the gamut of making sure there is no endometriosis, that there's no chronic inflammatory disease, that there's no comorbidities, no medical disorders. And then even with IVF, if there's no pregnancy, then we would start to talk about either egg donation, maybe sperm donation, depending on how the blastocysts are formed. Do you suggest donors, even both sides had no issues? And that could be a possibility after 6, 7 years. And of course, it's very important, especially in the context of unexplained infertility, never say never. Remember, humans are very inefficient as reproducers. Half of your cycles, in your natural cycle, when you're trying to get pregnant, eggs are being fertilized by sperm, but that process of cell division just stops happening either in the fallopian tube or just doesn't appear to implant in the lining of the womb. The lining of the womb is a very important organ as well. It has to read and synchronize with the egg and the blastocyst to make sure that they're all matching up together. It's a very, I mean, in the context of humans, we're not designed to have many children. Obviously, the earlier you have children, the more fertile you are, as long as there's no pre-existing conditions. But humans, even though in your 20s in university or wherever you desperately tried not to get pregnant and use contraception perfectly, when you do try to get pregnant, especially the majority of women that we would see would be above the age of 30, like your chances of getting pregnant every menstrual cycle where there's ovulation, normal sperm, no coexisting problems, is anything between only about 10 to 15%. And even with that, couples who've tried for a year and in the age bracket under about 36, that does drop down to about 5 to 7%. And that cohort of eggs and sperm, sometimes it takes 2 eggs to make a baby, so people are pregnant after 2 cycles, and sometimes it takes about 60 to 80 eggs to make a baby. It's so variable, it's very difficult, and this is where a lot of people would come under the unexplained infertility banner. What do you recommend for women who aren't ovulating? So that wouldn't, obviously that's an explanation for infertility. So ovulation disorders, there's different types. So some majority of people would be aware of a condition like polycystic ovarian syndrome, where women have a condition that's both gynecological and metabolic, and the brain and the ovaries just aren't kind of giving that negative feedback loop to each other, and eggs aren't being released. So in the context of polycystic ovarian syndrome, where there's no ovulation, the first line treatment we use, if there's no problems with sperm, is a simple tablet called an anti-estrogen called letrozole. Some people might have been familiar with a drug called Clomid that was used as a first line treatment up until about 2 to 3 years ago. So that's normally what we use as a first line treatment for women who aren't ovulating. It depends. Some women have other ovulation conditions where there's hypothalamic problems, so where from the brain, the woman isn't kind of like brain and ovaries aren't talking to each other because either very thin, recent major weight loss, eating disorders and things like that, and therefore we use injectable medication called FSH. But for women who do ovulate, using those medications don't increase your chance of pregnancy, and that's an important aspect. It's not going to increase your chances because you're already ovulating, and sometimes the anti-estrogens can affect the lining of the womb, so that negatively impact on trying to get pregnant. Are there any risks with using progesterone pessaries until 7 weeks gestation? No, not necessarily. Progesterone pessaries, for those who aren't aware, is just luteal phase support, and they sit in the vagina and they're absorbed through to the uterus. They are used, obviously, in the context of IVF to support the implanting embryo. Some people use them where they've had miscarriages in the past, and some people use them where they have used ovulation induction in order to correct that for pregnancy. And then how much does removal of superficial endometriosis affect IVF success rates? So that's a very good question. Superficial endometriosis may or may not cause infertility, and also severe endometriosis may or may not cause infertility. But if it's very superficial, IVF will usually result in pregnancy without having to remove the superficial endometriosis. But in the context of removing superficial endometriosis and natural pregnancy, that's where we do see better pregnancy rates, where couples are encouraged to try for about a year, for about 6 months to a year after they've had surgery for endometriosis. Obviously important, factoring in the female age. It's very difficult to put just kind of a one line, what is unexplained infertility, but a few pointers to take home. It's very important to seek advice about fertility, either via your GP or maybe a gynecologist that you've previously seen, and to see what's going on. If you haven't achieved pregnancy after 12 months of trying, under the age of about 36, if you're over 36 and over, just because age does become more of an issue after about 6 months of trying, and that's really just to make sure there's no issues. It's important to have the right tests done at the right time. It's important to think about lifestyle factors, and especially say if the male partner smokes or has uses marijuana or illicit drugs. And it's important to seek information early, because it does take a while to get pregnant, and some people take longer. And it does also, where people might know they've got endometriosis and things like that, sometimes it takes a while for surgery to take place, and then to wait another 6 to 12 months for pregnancy to happen. In the context of everything's normal, why aren't we pregnant? There is treatment available for that. So we do have treatments such as using ovulation induction with intrauterine insemination. So that's where we use some medication that I was talking about. So I did say that ovulation induction wasn't useful for women who are already ovulating, but in the context of unexplained infertility, if we use a small amount of medication and put it with spinning the sperm down to get the very, very fast swimmers and put them into the uterus prior to ovulation, so in a very timed manner, so where we monitor the cycle. So it's like starting the marathon at the halfway mark with the fastest runners. That's called ovulation induction with the IUI. So that can be used for unexplained infertility, and we do see increased pregnancy rates. And ultimately, some couples do have to resort to fertility treatment, as in IVF, so in vitro fertilization, either where we allow the sperm swim up to the eggs naturally in the petri dish in the lab, or where we have to singularly inject each egg with the sperm, depending on the sperm the male gives us on the day of the female patient's egg collection. And IVF will obviously give us a lot of information as to why people aren't getting pregnant in the context of unexplained infertility in the first place, where we don't have an answer to that. What are your thoughts on adenomyosis affecting IVF success rates? So adenomyosis is a condition where the lining of the womb grows inside into the muscle of the womb, because remember, the uterus is a muscle, and then it has this lining that you shed every month with the period, and then the lining is also that very important cushioned cushion where the little ball of cells arrives from the fallopian tube in a natural pregnancy, or it's where we put the embryo in. It's a very can be quite a debilitating condition for women, where it causes very heavy periods, because obviously if the lining of the womb is going into the muscle of the womb in the context of when periods happen, the uterus kind of is trying to squeeze the blood out, but if there's pockets of lining of the womb in the muscle, it can significantly impact on the heaviness of the period, the flow, and also pain. It is synonymous with endometriosis. So if we see adenomyosis on ultrasound scan, because remember, endometriosis might not be visible on an ultrasound scan, because the most effective way of diagnosing endometriosis is by doing a laparoscopy, where we put a telescope into the belly button when under general anesthesia. But we can see adenomyosis on an ultrasound scan. So that's another reason to get a good high-resolution ultrasound scan in a gynecology imaging department. And adenomyosis might coexist with endometriosis, which ultimately may affect IVF rates. But unfortunately, you can't surgically remove adenomyosis, because that means you're kind of going into the wall of the womb and taking out pieces of the wall of the womb, which can lead to problems with scarring and things like that that can adversely affect pregnancies. So sometimes treatments for adenomyosis are medical, where we try to reduce those pockets in the lining of the womb just by kind of suppressing the ovaries, by long-term use of the pill. I know it seems counterintuitive when you're trying to get pregnant, but sometimes women who have bad adenomyosis, where embryo transfers are failing, we do resort to medical treatment, kind of dampening down that effect for about 3 to 6 months before we do any further embryo transfers or fertility treatment. So I hope that answers your question. Why are ectopic pregnancies more common in IVF? So when we transfer the embryo back inside the uterus, we transfer it under ultrasound guidance, because we're optimally going to place the embryo in the upper mid cavity of the uterus. Unfortunately, sometimes the embryo can travel into the fallopian tube as a result of possibly being placed too high in the uterus, or just simply the pressure of the embryo transfer itself. So your background risk of having an ectopic pregnancy with no tubal disease is about 1%. That increases to about 3% in an IVF pregnancy. So it is important to have a single embryo transfer for the majority of people. So that's putting one embryo at a time. And when people do get pregnant, we always check their blood levels to make sure that their hormone levels are going up accordingly, so that we're not missing an early ectopic pregnancy. So sorry about the interruption today, and I hope I answered as many questions as possible. I think we might wrap up the session for this evening. So the take-home message is that unexplained infertility does account for about 25% of couples presenting with a delay to conceptions, which by definition is about 12 months of infertility. That's regular sexual intercourse mid-cycle for approximately 12 months. The most important thing is unexplained infertility probably has a good prognosis, because we do see of those couples who have fertility treatment, statistically, they do get pregnant naturally themselves, about 20 to 30% of those couples, especially in women under the age of about 37, 38, for subsequent pregnancies. So definitely never say never. The human body is a very complex fertilization mechanism, and therefore sometimes the unexplained infertility can just account for that. It takes statistically some people anything between 2 to 3 to 4 years to get pregnant naturally. Artificial treatment can help in the context of trying for after trying for about 12 to 18 months, a laparoscopy and a hysteroscopy, so that's looking inside the uterus and making sure the lining of the womb is indicated for women who do have unexplained infertility. IVF overall can treat unexplained infertility and does have a good success for women usually under the age of 40, between 40 and 43 obviously fertility, that success does decline. But I'll be very happy to answer any further questions. And thanks for tuning in tonight to the Facebook session. I wish you all very well, and anyone who is trying to conceive out there, hopefully that you'll be able to have that good day soon when you have a positive pregnancy test. Take care.